Hey again, now we're going to learn how to diagnose and treat OA and AA in about 16 minutes. When we're talking about OA, we are talking about the O standing for occiput, A standing for atlas. So O standing for occiput, we know that's the back of the skull here, and we're talking about the occiput moving. So the occiput is the one moving on atlas, or C1. If you keep forgetting that C1 is Atlas, remember that in Greek mythology, I guess Atlas was the guy that got punished and had to hold the whole world up on his shoulders. And that's literally what C1 has to do. It has to hold the whole head up. So that's what early anatomists thought of it when they saw C1. One thing with OA, I like to look at the O, even though it stands for occiput, it reminds me of opposite. Because with OA movement, if it's side bent one way, it's rotated the opposite direction. Unlike typical cervicals, remember, like having a typical day, it's easy. So typical cervicals are easy and they side bend and rotate in the same direction. But with OA, remember the O stands for occiput in our mind. So if we're side bent to the right, we're rotated to the left. On to AA. So the first A stands for C1, which is Atlas. And then the second A stands for axis, which is C2. And axis in anatomy stands or means axle. And an axle is just a rod through a wheel. And I have, here we go. If you can see this, that little process, that's the odontoid process, also known as the dens. And so that actually goes through C1. And so that's like the rod that's going through the wheel. So that's why it got its name. Now with AA, there's no side bending. Technically there's a little, but we ignore it because it mainly just does rotation. And the way that I remember AA does rotation is rotation, because AA, like think of a long A, so rotation is done by the AA. Versus OA, OA is mainly your flexion and extension. So OA is your yes joint, AA is your no joint, doing rotation. Hopefully you don't forget that now that I said that like 4 times. So moving on to how to diagnose OA. So to diagnose OA, we find the occiput, the back of the head, and you're going to slide off until you don't feel the occiput bone anymore. So you gotta fall off the occiput, and then you're going to, instead of going further down where you can feel that first bony projection, which is the spinous process of C2, like we talked about in the video before this, we don't wanna go down to C2. We want to actually feel ourselves slip off the occiput, and right when we do that, we want to start going forward, kind of like towards the patient's jaw. So you want to go forward towards their face, and as you're going under the skull here, you want to kind of act like what Dr. Weston says, like flipping someone off, because you're going to fall off of the occiput bone, you're going to go forward, and you're going to flip someone off by curling your fingers to get into the occiput. Now you don't want to be midline, you don't want to be where the spinous processes are, like in that line, you want to be a little bit more lateral. And you want to do this with both hands. I usually do 2 fingers, but maybe if you have bigger fingers, you'd use 1. Not totally sure on that, but that's just what I do. So I'll have about 2 fingers. I think I use my middle finger and ring finger for me with both hands. Here, I'll do it this way. So we go into the sulcus and we're curling our fingers. And I just want to feel in there, like, is there one where I can barely fit my finger versus one where it feels more roomy? So if on the right side it feels super narrow and like there's not a lot of space, that means the right sulcus is narrow. Now whichever sulcus is narrow is the side that I'm side bent to. Because if you think about it, I just bought a plant because I wanted a pet and realized I don't have time for a pet. So this is my plant. And if you imagine this being side bent to the right, the space right here gets very narrow, and then this side gets deep because it's tilted away from it. Hopefully that makes sense. I'll do it with the actual occiput now. So on my hand, if it is rotated, or sorry, side bent that way, so we're side bent towards the right, that means the right sulcus is going to be narrow because the head's like squishing everything on the right. And then the head's away from the left side, so it's really roomy. The other thing you do after you put your fingers over here and you feel that the right sulcus is narrow and the left sulcus is deep, so we know that we are side bent to the right because we have a narrow sulcus on the right. And then because it's OA, it's O for opposite, so we're side bent to the right, which means we're rotated to the left. And what we're going to do is we have to like double check ourselves. They like us to do the cephalad traction. Traction just meaning pulling versus compression is like pushing. So traction, we are pulling. So in this case, we'd be pulling the head up toward ourselves, and cephalad would mean head. So we're pulling towards the head instead of like pushing towards the feet. So cephalad traction, I'm still going to have my fingers in the same place in the sulcus on both sides, and I'm just going to pull their head towards me. And if I'm testing this right sulcus that's narrow, I'm going to pull towards me. We're testing the right, so I'm actually going to side bend to the left because I want to test those muscles, because if someone's head is rotated this way, the muscles on this right side are used to the head being closer, so they all shortened. So they're like constantly contracted, they're tight, and then so if I have my hands here, I'm pulling and I'm side bending the opposite way, just like pulling a little. We're not just pulling straight like this. We have to pull and pull to the opposite side. If those muscles are really tight because they're used to the head being like this, it's going to be hard to pull up. So if you can't really use any traction on that side, that's probably the narrow side. Versus on the left side that had a deep sulcus, if I pull up and side bend the other way, if that's easy, that's probably the deep sulcus. I hope that makes sense. Text me if it doesn't. Now figure out if it gets better in flexion or extension, just like we've done in the typical cervical video. But basically, you're going to nod forward. One thing that's a little different between the typical cervicals is your C2 through C7 are a little bit lower than your OA. Your OA is all the way up here, so you don't need a lot of motion. It really just needs to be like a little nod. It's like a little chin tuck, and that's it. So if you're flexing your patient like this, saying that you're treating the OA, you passed it, because you just want to wait until you feel just a little bit of motion in your fingers and then stop. You don't want it to go past that. So we're going to flex just a little bit like that, and I'm going to see if the sulcus got more symmetric on both sides. Let's say that it did. And so we would know that your diagnosis for OA is it's flexed, it's side bent to the right, because we said we have a narrow sulcus on the right, side bent to the right, and we are rotated to the left. There's one other way to diagnose OA, and you need to know it for your exam. So what we're going to do is we're going to put our hands not in the sulcus, but we're going to just have our fingers on the occiput. We're going to push it to the left and push it to the right. And it should sound really familiar to what you did with the translational method with your cervical bones, your typical cervical bones. And it's the same thing. So let's say I push it to the right and it moves really well, and I can't push it to the left. So like Dr. Weston's way of thinking, if you can't push it to the left, then you're side bent to the left. Or in my way of thinking, if you push it to the right and it moves really well, then it's just side bent the opposite way. So that's the other way that you can diagnose it. And then again, figure out your flexing, which is just a little bit because it's the OA. It doesn't need a lot of flexion, and see if it gets better. So let's give an example. Let's say that I'm feeling the sulcus and it's narrow on the left. So if it's narrow on the left, that means we're side bent to the left. And another way you can do that is you can double check yourself with the cephalad traction, which is you could test the left side by pulling towards you and to the right. So you're pulling away from that left side. And if it's not wanting to move because those muscles are so tight, that means that's the narrow side. So again, the narrow part is on the left side. The narrow sulcus is on the left side, so we're side bent to the left. The other way you can do it is by just feeling the occiput. You're going to push it to the left, you're going to push it to the right. It moves really well to the right, and it won't move to the left, so it's side bent to the left. With OA, O stands for opposite in our minds, so we're side bent to the left and we're rotated to the right. Now let's find out if it gets better in flexion or extension. So you're going to nod forward just a little bit because it's OA, it doesn't need a lot of movement. And I'm going to monitor the sulcus on both sides, and I'm going to feel if it gets more symmetric. So that means neither one is more narrow or deep. And let's say that it got more symmetric. I can also use some cephalad traction and see if that's symmetric as well in the movement. And let's say it is. So that would mean that OA is flexed. You'd also check extension, but let's just say for this, we found out that OA is flexed, and we said that it was side bent to the left because we had a narrow sulcus on the left, and we're rotated to the right. So now let's treat it. So we're gonna put our patient into their barrier because we're using muscle energy, which is a direct treatment. And so because we were flexed, side bent left, and rotated right, what is your treatment position? I'll let you pause the video and I'm gonna say it. So you are going to extend, you're going to side bend to the right, rotate to the left. And one thing you want to do with OA, use one finger, or one hand, two fingers to monitor the sulcus so that you can use this hand to do something with the chin. So in this case, the patient was flexed, so we're going to have them be in the treatment position and they're going to try to flex downwards. So my two fingers are going to be under their chin and I'm going to ask them to try to nod forward, nod down, however you want to word that. So they're going to try to look down, I guess that's a better way to put it, while I resist for 1, 2, 3, 4, 5, relax. I'm going to further extend, further side bend to the right, and further rotate to the left. And remember, it's just a little bit of motion. Like if you saw someone doing this treatment, you probably wouldn't know that they're even doing these movements because they're so slight. And then I'd have them do it again. So I'd have them try to look down while I resist for 1, 2, 3, 4, 5, relax. We do it again, and then we do a passive stretch in extensions, side bending to the right, rotating to the left, and then I put them back to neutral and reassess. I do want to note that if your patient has an extension dysfunction, so the opposite of what I showed you just now, if they're naturally extended, I'm going to put them into flexion and, I don't know, side bending to the left, rotating to the right. And then I'm going to let them do what they naturally like to do, which is extend for muscle energy while I resist. So that means while they extend, I have to resist by putting my fingers on top of the chin now instead of below. So if it's a flexion dysfunction, I would be putting my fingers under the chin and positioning them in extension and let them try to look down. Versus if they have an extension dysfunction for muscle energy, I would flex them and let them look up while I put my fingers on top of their chin to resist. On to diagnosing AA. So AA, we know, is atlas movement on axis. So C1's the one that's moving. And we know that it has to do with rotation because AA. And so that's your no joint. And the way that we're going to diagnose that, this is kind of your weird one where you have to stand up. So pretend like I'm standing. They do that just for better body mechanics so that you don't get tired when you're holding someone's heavy head. So nothing against them. But you're going to hold their head and pretend like you're standing. Well, actually stand. And you're going to flex them at least 45 degrees. Really, it's until you feel resistance. So a lot of people, especially younger people in their 20s, you can flex their head really high up. And keep in mind, they're supine, so their whole body is still laying down, and you're bringing like their chin to their chest. And then once you get that, you're locking out all the other cervicals so they're not moving, and you're holding their head, keep it flexed, and then start rotating them while keeping it flexed. And let's say I rotate to the right and I get 45 degrees until I start to feel restriction where they're not moving well. And I'm going to rotate to the left and keep it flexed, and rotate to the left, and I get 20 degrees of rotation on the left. So which side can they rotate more to? The one that has more degrees. So it would be to the right. I think I said 45 degrees instead of 20 on the left. The other way you can diagnose AA, which I like better because it takes less energy, is just have them lay supine like you normally have them do, and you're going to feel C2. So remember to find C2, you find the occiput, slip off of the occiput, you're going to feel a soft space where there's no bone that you can feel, and then you go down a little bit, just go down the spine like a centimeter or something, and you'll feel bone. And that first midline bone is the spinous process of C2, because C1 does not have a spinous process. It has a little posterior tubercle that's too far forward for you to feel. So you find the spinous process of C2 and go lateral, go out, because you want to go back on the articular pillars. So here's C2, here's the spinous process that you found, and you want to go lateral, go out to the posterior part of the articular pillars, right here and right here. And what you want to do, because AA has to do with C1 moving. So once C1 cannot rotate anymore, C2 will start to rotate. And that's how you know that C1 is done rotating, by C2 starting to move. So you're going to feel the articular pillars of C2, and you're going to start to rotate to the left, and there's no movement, and all of a sudden I feel movement of C2 articular pillar. It's starting to move posterior. So I would go, okay, I don't feel any movement. Now I do at 20 degrees on the left. Let's try it on the right. I'm still going to feel for the articular pillar on the right, and I'm going to rotate my patient's head to the right. I'm not feeling any movement, and I start to feel the C2 articular pillar move posterior around 45 degrees. So I would know that the right side still has more motion. Muscle energy of the AA is great because you only focus on rotation. So for the first one, you can flex their head all the way where they're still supine, they're laying like that, and you bring their head, basically their chin to their chest until you feel resistance. And then let's say that they were rotated to the right. If they're rotated to the right, I'm going to put them in their barrier, which is rotated left. So I'm going to rotate them to the left because they don't like to do that. And I'm still going to keep flexing their head, even though they're laying down. And I'm going to wait until I feel some sort of restriction, which means I'm moving it and all of a sudden I can't move it anymore. Once I found that position, that first barrier, I'm going to put my hand somewhere on their cheek, probably, and cheek or mandible area, and I'm going to tell them to try to turn to the right, the way that they like to go. And I'm going to have them do that while I resist for 1, 2, 3, 4, 5, relax. I'm going to further rotate them, and then so on. You guys know how muscle energy works. And then the other way that you can do it, if you diagnose them while they were just laying down, this is the lazy way that honestly I like, but that's where you're feeling the C2 articular pillars. And again, let's say that they're rotated to the right, which means for muscle energy, you're going to rotate them to the left. So you're going to rotate them to the left until you start to feel restriction. You would have them look to the right while you resist for 1, 2, 3, 4, 5, relax. Further rotate them to the left until you feel that C2 articular pillar move, and do it again. At the very end, you would do a passive stretch, turning to the left, and put them back to neutral and reassess, and that's it.